Good evening, everyone. I am Abdul Hussain, member of FCPI. Welcome you all to the first basic module presentation in the Research and Publication Forum. So the first topic for the forum is the Basics of Evidence-Based Medicine Part 1 by Mohammad Rashid. So research and publication plays a fundamental role in the realm of clinical pharmacy. It is not just for the academic exercises that one has to accomplish during one's academia, but it is a powerful tool that shapes evidence-based practice and drives innovation in patient care. So I welcome Mohammed Rashid, sir, will take us through technology at Manipal Academy of Higher Education. Sir has published more than 80 papers in national and international journals. Sir is also the regional head of the student network for the Asia Pacific region. Without further ado, I would like to invite Rashid sir to begin the session. And just before that, there are some guidelines for the participants. So, yeah. So one can post their questions or responses in the comment box given below in the YouTube streaming service. Your questions will be discussed during the Q&A session at the end of the presentation. Thanks. One can submit their feedback, which will be available below the comment box, and the feedback form will be disabled after the live session. Next up. For the certificates, it will be available after 14 days of attending the event, and one must log into our website and register for the event to claim the certificate. So after the completion of the presentation only, the PDF slides of the presentation will be available to download. But for that, the login is mandatory for the FCPI website. Next. Over to you, sir.
Thank you. Thank you so much, Abdul, for giving such a nice introduction. And thank you everyone for joining this session. And this is the first session from FCPI on behalf of Research and Publication Forum. And as Abdul was clearly mentioning, Research and Publication Forum is launching and it's their first presentation. And we will have more activities coming up. So stay tuned for the further activities. And today we are giving a basic understanding of research and publication and the basics on evidence-based medicine. So this session, I'll be just giving an overview, like what is evidence-based medicine and what is the level of evidence and what is the strength of recommendation. So today I'll be just telling about these three aspects. And next month we will have the second session of evidence-based medicine, and we will be discussing in detail on different study designs which we are using in the clinical research, pharmacoepidemiology, and other evidence synthesis. So stay tuned and be within all the sessions on evidence-based medicine. Without much delay, I'm just moving to the presentation. So we all might be hearing evidence-based medicine and evidence-based medicine during our the regular activities, during our clinical rounds, or during our decision making in the clinical activities. We'll be always hearing evidence-based medicine. So we will see what exactly is evidence-based medicine. Are we thinking the same what it is? So the thing is, like, there is like something called it as evidence-based medicine and evidence-based practice. The thing is, like, whenever you are taking any evidence or whenever you are doing properly according to the evidence, then it is called it as evidence-based medicine. And that evidence you are using for your regular clinical practice, and you are applying that in your particular scenario or the setting or what where you work, then it is referred as evidence-based medicine. So basically, evidence-based practice is the practice of evidence-based medicine. So we will come back to evidence-based medicine. So evidence-based medicine, like usually the people will get understand or the people will get confused. Evidence-based medicine means only the research or only the reviews or only the literature what we get. No, evidence-based medicine is having multiple dimensions. It is a club of multiple aspects. So obviously, the best research evidence or the literature evidence is the first part of that. So what exactly we need to do when you adopt the system of evidence-based medicine in your regular practice? Obviously, you need to look into the literature. Obviously, you need to see what the literature evidence is telling about that. It is not only just checking what the evidence is telling, rather than you are choosing the best possible adoptable evidence. It is not just taking some evidence. No, evidence, when you practice the evidence-based medicine, you need to pick the best evidence. Not only just picking the evidence, you need to check what is the quality of that evidence, what is the level of evidence of that evidence, whether I can use that evidence into my practice or not. So you need to pick, you need to choose the best research evidence, or you need to choose the best literature evidence what we are getting from our multiple databases or the across the world literature. So that is the first part. Obviously, in the evidence-based medicine, the best evidence is the first part. Is that only enough? No, you should have a proper ability. You should have an ability to interpret that finding. Not only interpreting that finding, along with interpreting that finding, you should have a clinical expertise. You should have a clinical expertise. You should have a clinical experience. What you know about that evidence as a healthcare professional, as a pharmacist, as a clinician, what you know about that particular area. You can't simply take an evidence and just put that into the patients. No, it is not possible. What you need to know, you should have some experience in that particular setting. As a pharmacist, when you work in the critical care, so you should be more applying the evidence-based medicine only in the critical care, not in any other discipline, because you don't have clinical expertise in other domains, because you are expertised in the critical care medicine. So when you apply evidence-based medicine in a particular setting, in a specific area, you should have clinical expertise. You should have a clinical experience in that area about what actually the patient treatment, how it is going on, how the patients are getting suffered, how you are utilizing that treatment in that patient. Then this clinical expertise along with your clinical literature evidence, you are going to decide what you are going to give to the patient. Now, the third part is not only the literature, what it says, it's not only the clinical experience, what you have, along with always patient is the priority. Always patient, people are priority. So what you need to do, you need to see what patient is exactly required. What always literature says may not be able to apply in the patient. There will be some contraindications, or there will be some situations where you are not able to completely adopt that situation into the patient life. They are not properly adopt into the directly into the patient requirement. So in that case, what you need to do, you need to see what the patient values, what is the patient rates, what exactly patient is required. So if the evidence is completely fulfilling what patient is actually required, and according to your expertise, you are able to translate that evidence into your practice, then you can go ahead. If not, is there any situation where you need more evidence, you need more expertise, you need more modification? What you need to do, you need to consider the patient values. You need to see what exactly patient is required. Yeah, and then you need to modify the currently available evidence. Then you need to apply into your patient. So actually, when it talk about the evidence-based medicine, obviously literature is the part of the game, and clinical expertise is the other part of the game, and lastly the patient values. It's not the last, but it is the most important one. But it will be the evidence-based medicine will be a club of all these three, and when you practice that into the your setting, then that is called it as evidence-based practice. So this is the basic understanding on evidence-based medicine and evidence-based practice. So today I'll be more of talking, or today as well as the next session will be more of talking about what literature evidence we have. Not only what literature evidence we have, we'll be checking how you are going to take this literature, how you are going to see what is the strength of recommendation of the literature, what is the hierarchy of level of evidence in that literature. So I'm moving to my slide. I hope you are clear with what exactly evidence-based medicine is all about. Now, what we do usually when we apply the evidence-based medicine, or whenever we see any kind of situation comes in front of us, what we first look is always clinical guidelines or clinical policies or treatment policies, treatment algorithms. So we have that properly defined guidelines to use in any clinical setting. So if you see the definition of a clinical guidelines, clinical practice guidelines are systematically developed statements to assist practitioner and patient decision about appropriate healthcare for a specific clinical circumstances. So basically, that will help the clinician, that will help the healthcare provider to provide the best possible treatment in a particular setting, and that has been developed by a group of experts or the peers or those who are having the expertise in that area. So we have some examples of some guidelines. You might be always using these guidelines, like Standards of Medical Care in Diabetes 2020 International Society of Hypertension, Global Hypertension. And it is there in the all settings. You can see any setting. You go for asthma, we have GIRA guideline, we have COPD guidelines. So we have each disease, we have separate guidelines. So when you go to the critical care, we have European Society of Critical Care Medicine guideline or Indian Society of Critical Care Medicine guideline. So there are guidelines, multiple guidelines. So first what we check always when it comes to the practice is always a guideline when as a healthcare practitioner. So now this is what is guideline. And when it comes to the guideline, whenever you read guideline, you might be observed that after a statement, after a particular statement on any kind of treatment, suppose the treatment guideline is telling that drug A is comparatively better than drug B. So when they say that, they'll be putting a quote along with that. This evidence is based on literature evidence. So it's not just making a recommendation. So whenever they make a recommendation, they'll be telling you what evidence they have used for that particular statement, for that particular recommendation. That is what exactly the one part of evidence-based medicine. So what I do, I just took as like one example of 2020 diabetes guideline. And if you read, because we more focus as a clinical pharmacist to the pharmacological treatment of that particular condition. So when you see this guideline is having ninth chapter talking on pharmacological approaches to glycemic treatment. And if you see the recommendation, what they're saying, this is obviously 2020 recommendation. There might be some kind of modification or addition or deletion. So I'll just read the first statement. You see that the first recommendation 9.4 is telling that metformin is the preferred initial pharmacological agent for the treatment of type 2 diabetes. So you see, after that statement, they're clearly mentioning one letter, which is A, which is A. So let's see the next statement. Once initiated, metformin should be continued as long as it is tolerated and not contraindicated. And there is other agents, including insulin, should be added to the metformin. So that is also evidence here. So if you see 9.10, you can see that in patients with type 2 diabetes who need greater glucose lowering than can be obtained with oral agents, GLP-1 receptor agonist can be preferred to insulin whenever possible. So that recommendation they mentioned as B. This is what exactly we are talking in our presentations. What is this A means? What is this B means? There are other letters also, like sometimes they'll keep C, D, E, or sometimes what happens, even they don't keep A, B, C, D. There is a situation where they will keep Roman letter 1, 2, 3 like that. So it depends on the guideline developers, it depends on the policymakers, or it depends on the expertise or the team who is developing this guideline. Either they can mention A, B, C, D, E, or they can mention Roman letter 1, 2, 3 like that. So there are multiple guidelines for that to decide the uh, level of evidence. Now the thing is like what is the importance of these letters? So if you are not familiar with these letters, so there is a kind of, see, the recommendations are always to be used with the patient, as I was mentioning in my previous slides. It has to be, your expertise has to put into that. It's not always directly you are translating the research literature or the guideline to the patients. No, you need to put your expertise. So when you put your expertise, you need to see what exactly is evidence is, what A mean, what B means. There is a set of rules to decide A, or whether you should go with A over B. When you have A and B, both evidence, what you should do. When you have everything in A, what you should do. Which recommendation you should take, how it should be applied. So there is much more to about that. So I'll just see, or we will just see how it will go. Okay. So this is also, you see, I have just marked a bit more highlighted. So you can see that there 9.1 is A, 9.2 is A, again 9.3 is C. It is a C recommendation. They mentioned that it is C. So we'll see what exactly is this. So these kind of letters, these kind of Roman letters abbreviation or the denotation, that is referred as the levels of evidence, or we call it as level of evidences. So it is the actually the there is a hierarchy, there is a classification of evidences. What evidence should be given the priority? What evidence don't have to give the priority? If that prioritized evidence is not available, what we should do next? So there is a set of guideline for that. We will discuss one by one. Okay. So you see, I already told you. So that particular American Diabetic Association evidence grading system, they used ABCD and they clearly mention what is mean by A. So there you see the definition what they have given. So the A letter indicate that it is a clear evidence from a well-conducted, generalizable, randomized, controlled trial that are adequately powered, including a well-conducted multi-center trial, or is it is a meta-analysis of high-quality writing in the analysis? That is referred as A. That is referred as A. So they're taking that rule. When they say that that recommendation is derived from A evidence, is indicating that that evidence will be from a multi-centric, highly powered, a good quality meta-analysis of RCTs, or it will be a high quality generalizable randomized controlled trial which is conducted in a multi-centric setting. So that is mean by A. So you go further. Suppose that is not available, then even you can you see the point supportive evidence from well-conducted randomized controlled trial that are adequately powered. It may include one or more institutions. So either it can be, so they're giving that priority. The top priority will go to the multi-centric, well-conducted, generalizable randomized controlled trial with adequately powered number of participants. So that will be given the top priority. If that is not available, then they consider a single center international or generalizable randomized controlled trial. So that is mean by A. So obviously that is having the highest priority, or it can be an evidence which is generated from a meta-analysis of RCTs, and that RCTs should have high quality rating. So if that is the situation, high quality rating in the sense, it should be having lower risk of bias. In that case, they will be considering that evidence as A then that will be given the topmost priority. And if they say that it is an evidence A, it can be easily interpreted, it can be easily generalized to any set of population. That is the advantage of having an evidence A. So you see that B, evidence B, I shown you that, right? So we have evidence A, we have evidence B, we have evidence C, like that. So you see the definition what they gave for evidence B. You can see that this evidence is from a well-conducted prospective cohort study or cohort study of registry data, or it can be an evidence from a well-conducted meta-analysis of cohort studies. So if that case, they will be giving B. So sometimes we can't say always the RCT is the best. No, it's not possible, because some cases we may not be able to do an RCT, or there are some cases, especially etiological studies, or you are looking for a long-term like adverse drug reaction, or you are looking for a long-term harmful effect of a drug. You can't have an RCTs there. So that time you will be going for the cohort studies. That's why those kind of outcome, not immediate outcome, or it may not happen in 1 or 2 years, or it is a long-term outcome of the drug. Like suppose if I say one example, like you are checking for that what cardiovascular outcomes are happening over a long period of time among the patients who are using DPP-4 inhibitor, or those patients who are using metformin. So it will take long time for them to generate a cardiovascular. It is not from diabetes I'm talking. I'm talking about the cardiovascular outcomes caused by the drug. So that will take so much of time. So that time you may not have an RCT on that. What you need to rely upon? You need to rely upon a long-term cohort study. And if that long-term cohort study is happened in a well-conducted way, and it is from a registry which is having so much of cases or good number of powered data, then that will be considered as evidence B. So it depends on the research question, or depends on the requirement. Sometimes it will be a theological research question, or it interventional research question. So the study design will be given the priority, depends on the research question what you have. So this is the grading system which is adopted by the American Diabetic Association to develop that particular guideline. So that is what I just want to show. So here you see the ABCD, and if you as a decision maker, you as a clinical pharmacist, you as a clinician, if you are not able to interpret these evidences, the thing is, like, we may not be able to properly translate the literature into the clinical practice. Rather than, I could say, we may not be able to properly practice the evidence-based medicine. So that is the importance of understanding these levels of evidences, understanding the literature evidences and all those things. So I hope I'm clear what is meant by these levels of evidence. So we have a system. You see these levels of evidence. I said you that. So there is a priority. So we have some filtered information. We have some unfiltered information. We have some even expert opinions as well. So we have multiple evidences which we get from the literature. So if you see the filtered information means those information has been collated or summarized or properly screened and collected by the experts to develop on a particular topic from the available primary research. That is meant by filtered information. In that category, we have systematic reviews, we have meta-analysis, we have critically appraised evidence in the topics like your guidelines or some kind of consensus, such kind of things. Then critically appraised individual article. Sometimes if it is a practice changing article, if it is a very good article, they individually scrutinize that article. They'll be checking the appraisal, or they'll be doing the critical appraisal of that article. Then they'll be providing some information. So if that information has been clearly given, that is referred as the filtered information. So otherwise, all the primary researchers, you know that system, like we have RCTs, we have cohort studies, we have observational studies, we have our case control studies and all other study designs which comes under the umbrella of pharmacoepidemiology or clinical research. All these will go to the unfiltered information, because nobody did the checking of that particular research. Nobody did what that particular research is telling, whether it is done appropriately or not. So that's why we have to call it as those evidences are from the unfiltered information, and though these evidences will go after the filtered information. As the pyramid goes above, as the filtered information goes above, it is having more quality. So that is the implication of this evidence pyramid. So it is more clearly at the definition of level of evidence or hierarchy of evidence. It is assigned based on the methodological quality of their design. There are multiple criteria to assign the levels of evidence. I'll explain in the coming slides about that. So one criteria is that, as I said, it's a methodological quality of their design. You might be seeing the previous slide. They're clearly saying it is well conducted randomized clinical trial, which is it happened in a multicentric approach, and it is adequately powered and having a good sample size. So like that, there will be some specification depends on the methodological quality. Always well conducted, large sample size study or adequately powered randomized controlled trial, always having a higher priority than a lowered sample size study. So like that. So it depends on the methodological quality. If they have done properly a randomization, that is having more priority than which is then not done a randomization. So then validity. What is the validity of the result? What is the credibility of the results? And how much it is applicable to the patient care? It's not only just done an RCT. No, that's not enough. It should be able to translate to your patient care. It should be applicable to the patient care. So that is important in case of levels of evidence. Then these decisions give the grade or strength of recommendation. So as I mentioned, A, B, C, D, it's called as strength of recommendation, or we call it as grade of recommendation. So that A is having more value than B, than C, than D. So that's how it works. So it is this able to decide what is the strength of this recommendation. So different types of clinical questions are best answered by different types of research design. So I said, I give you an example, right? Always we can't go with RCT. Sometimes we have to go with the observational studies, or sometimes we have to go with the cohort studies. So it depends on your research question. I given you an example. Say if you are going with an intervention, as I mentioned, you have to go with the RCTs. But if you are going with an etiological type of research question, where you are looking to the long-term harmful effect of a drug, then you need to go with the cohort study. So basically, your design, study design decision will be depends on your research question. So that's how it works. Then you might not always find the highest level of evidence to answer a question when this happens in a low quality evidence setting. So or walk away from the next higher level of evidence. So as I was mentioning, see, suppose it's an intervention, but you don't have a highly powered, good quality RCT. So what to do? You need to go for the next evidence. If meta-analysis is not available on that topic, go for RCT. Like I given you an example, like what are the filtered information, what is the unfiltered information. So if that filtered information is not available, don't rely, you don't say that we don't have an evidence. No, you need to check for next levels of evidence. So you need to come down in the hierarchy of evidence. So that is very important. That's why we should understand what is the level of evidence, when we should pick RCT, when we should pick cohort study. If RCT is not available, what next? So that is how we should work when we work with the evidence-based medicine. So that's about the level of evidence. Then we have some set of criteria for level of evidence. Like I said, another example, I given how that level of evidence is going with A, B, C, D. So this is another set of presentation. Like you can see that here they're saying instead of ABCD, they're saying that level 1, level 2, level 3, level 4, level 5. So you can use any kind of denotation. You can use any kind of presentation. It's up to you, but you should give proper referencing. You should give proper authentic reference for that particular situation. So here you see, if it is, they're saying that it's a level 1. It's a level 1. It's clearly indicated that that should be from a systematic review, or it should be from a meta-analysis, or it should be from a clinical guideline that include a minimum of 3 or more good quality RCT. If that situation is criteria is fulfilled, then only they will say that it's a level 1 evidence. Suppose they're taking from a single individual well-conducted RCT, it's a multicentric RCT, then they'll be just downgrading the evidence into level 2. Why? Because it's not from a meta-analysis, it's not from a systematic review, or it's not from a clinical guideline with minimum of 3 high quality RCTs. So that's how it works. So this is what I was telling. If that particular evidence is not available, then you need to go for next set of evidence. You see the level 3, if both are not available, like I said one example in the previous slide, if a well conducted RCT is not available, go for quasi experimental RCTs, go for non-randomized controlled trial, then you go for cohort study. So that's how that hierarchy of evidence will work. Always give the priority to the top. If it's not available, go for next, go for next, go for next. So then when you take that evidence, you are responsible to say which level of evidence you have used and what representation or what is the authentic references you given to grade that particular evidence. That's very important. So that's how it works. So I hope it's clear how we apply the levels of evidence into the our evidences when we take this is another pyramid. So this is what I was telling on the previous slide. So they given you some examples. This I'm presenting in a different domains, different kind of presentation, so that you will better understand how it works. You see that, as I was mentioning in the previous slides, see, always filtered information means you will have systematic review, you will have meta-analysis, you will have evidence-based, properly designed clinical guidelines. So that is the, or critically appraised proper clinical guidelines. So that is how the filtered information will go. Then when you come into the unfiltered information, there is a way how to pick those. So if it is a therapy, if it is an intervention, then you always go with the randomized controlled trial. Then only given the priority to the cohort studies. But if it is a etiology and that outcome is happening in a short time, again you need to rely upon the randomized controlled trial. Then you give the more importance to the cohort studies. But if the outcome is happening on a long term, where you cannot conduct a long-term RCT, then you need to go for cohort study. So it depends on your research question. It depends on your requirement what you have. Then you choose, then you pick which study design has to be given more importance and priority. So that's how the level of evidence will work. So I'm moving forward. I said you that there is some kind of recommendation we have how to grade these evidences or how to classify these evidences. So I'm just introducing one or two of them. Then if we have more other, so we can refer that further. So I'm just telling what is meant by grade recommendation. So grade is an approach, a system for rating the quality of evidences, and it is a body of evidences in systematic reviews and other evidence synthesis such as health technology assessment and guidelines and grading recommendation healthcare. So basically, grade is a framework. Grade is a framework, or grade is an approach to grade the recommendations, to strengthen the recommendation, to see how much good that recommendation is, how much not good that recommendation is there. So that's how grade work. So it gives a framework, it gives a proper framework, and if you follow that proper framework, you will be able to tell that whether that recommendation, that particular evidence is good for your going for the recommendation or going for the improve including in the clinical guideline. So if you use in the clinical guideline how good it is, how bad it is, you need to tell how it is. So when you do that, when you do the grade recommendation for a particular study, either you need to uphold the quality of the evidence or you need to downgrade the quality of evidence. So for that, like I said, either you give A, then you give B, then you give C. That's how I said to you how the level of evidence will work, right? So now there is a criteria to give on the top, next, next, like that. So for that, we use this grade recommendation, and I'll show you how we can use the grade recommendation. So before that, grade is having so much of advantages. That is why, because the grade is developed by a widely representative group of international guideline developers. So there was a team who worked behind the grade approach, and they developed this good way of recommendation, grade one, then to use in our recommendation tables. So there, it's a clear one, it's a good one, which is developed by a good international experienced people who were involved in the guideline developing. Then it's a clear separation between judging the confidence in the effect estimates and strength of recommendation. So this grade will give a proper clear statement to tell whether that can be used for the recommendation, or is it having a good strength of recommendation or not? So it's an explicit evaluation of importance of the outcome of alternative management strategies. It's an explicit comprehensive criteria for downgrading and upgrading the quality evidence. So I said that. So sometimes you will have to downgrade the evidence or you will have to upgrade the evidence. But for this grade will give a proper, explicit, comprehensive criteria when to upgrade, when to downgrade. So that's very important to understand. Then it's a transparent process of moving the evidence to recommendation. As I said, so you are not simply taking the evidence from the literature. Before that, you should do this particular assessment to see whether you can use that your clinical practice. So that's what it is telling. So this grade will give a proper transparent process for evidence to come to the recommendation or come to the guidelines or to the practice. So that's how this grade is working. So we'll just move how the grade is working. So this is a schematic representation of grade approach for synthesizing the evidence from the literature recommendation. Now, you see here, I'll tell you. So if this PICO and all, I hope you guys are already aware of that. So as I mentioned, you should have proper PICO framework to adopt the clinical recommendation or grade recommendation. Why? Because see, I'm using the same population. I can have diabetes population. I can have an intervention as a something like a DPP-4 inhibitor. I can have a comparator which is placebo, and I will have an outcome which is reduction in some kind of cardiac events or some kind of I'll say that weight reduction. So I'm using a PICO framework here, right? So we have a participant who are diabetes. We have an intervention which is a DPP-4 inhibitor. We have a comparator, something like a placebo, and we have an outcome weight reduction. Now this is one PICO. This is one PICO, right? So you see another PICO. I'll tell you the same one. I'll make in a different PICO. So the patient is diabetes with type 2. It's not type 1, diabetes with type 2, or diabetes with any other comorbidities, or diabetes who are having some kind of problems in their weight. Or like that, I can use P can be modified. Intervention can be modified. DPP, the dose X, the dose Y, the dose Z. So you can have multiple other interventions. So place comparator, you take either it will be a placebo, or it can be sometime it will be insulin. The comparator will be insulin, DPP-4 versus insulin, or it can be DPP-4 versus GLP-1. So there are multiple possibilities of developing a PICO. So each PICO should be properly evaluated before you give the recommendation. So that's how these things will work. So now you have proper PICO, you choose the outcome from that, which is how much it is important. So your first PICO will be more important, the second PICO will be less important, or it may not be that much important. So you need to see how important is your each PICO, how important is your each PICO. Then you assess the outcome. You assess the outcome in each studies you are assessing. Then you can use, there is a software which is Grade Pro. There is a software which is Grade Pro, and that use a proper way of how to apply this grade. Then you will rate the quality of evidence. And this quality of evidence, you will be rating as high, moderate, low, or very low. The quality of evidence, if it is high, that indicate that that is having the strongest recommendation, that is having the strongest strength of recommendation. So when if it is high, if it is on the top, it is having the for more better evidence. It is a very better evidence. So that's how it will work. So when you have a high quality evidence, when according to the grade recommendation, if the quality of evidence is high, that indicates that it is a very good option. You can go with that. So if it goes to very low, that means you are downgrading the evidence. If it goes to the very low, then usually it will not be recommended as a good strength of recommendation. So that will be downgraded and that will be taken out of your recommendation. Or if they're giving also, then they will be writing in the bracket, this particular grade, this particular recommendation is not strong enough, or it's a weak recommendation to practice in your clinical practice. So that's how they give the final recommendation. So I'll show you how they do that. So here you can see that now I said you how it works. you take individual PICOs, you take different research questions, you take the studies in that, you analyze the outcome in that. Finally, you are going to grade whether it is high, moderate, low, or very low. Now, if you want to downgrade, if it is you want to downgrade the evidence, what is the kind of situations you go for downgrade the evidence? So that is a situation to check when you downgrade the evidence. So the first one is risk of bias. Risk of bias, or we call it as methodological quality. So you see the risk of bias into each individual RCTs. So each individual studies what is the risk of bias. If there is a high risk of bias, if there is a high risk of bias, you will be downgrading that evidence. You will be downgrading that evidence. But if it is a low risk of bias, or if there is no risk of bias, you will be upgrading the evidence. So what is what I'm saying? Either you will upgrade the evidence or you will downgrade the evidence. So when you want to upgrade the evidence, it is indicating that that study should have a lower risk of bias. If it is having a higher risk of bias, you are going to downgrade the evidence. So that's why it will work. So now one first criteria is your risk of bias. Second one is inconsistency. There is something called as heterogeneity or difference between the studies. So heterogeneity means that there will be so much of variation between the studies. So in that case, you will be downgrading the evidence. You will be seeing the heterogeneity, or you will be seeing what is the various ways they explore the heterogeneity. So if it is convincing, then you can upgrade it. Otherwise, again, you are going to downgrade it. The indirectness, how much it is having the value to the practice. Then you have imprecision. You will be checking the effect estimate. You will be checking how much variation is there between the lower confidence interval to the upper confidence interval, or how much it is precise, whether imprecision is more, or you will be checking multiple effect, multiple aspect of that particular research. Then only you will be going to do the final grading for this particular research evidence. So now you have publication bias. If there is so much of publication bias, you'll be checking what is the p-value for publication. You'll be checking what is the Eggers or Beck's test analysis for the publication. So you'll be checking each and everything which influence the quality of evidence. Then only you'll be deciding whether that quality is that evidence is having a higher quality or lower quality. Then you will be checking the large effect. If they have done a large effect estimate, if they have taken a good number of studies, if they have a good number of participants in their study, so you will be giving upgrading that evidence. So if it is more number of participants, more number of studies, that indicate that it is having more grade, upgrading the evidence. Then it is if they have done dose response analysis, like I said, you will have dose X, dose Y, dose Z. If they have done a dose response effect, how the dose is influencing the result. So if they have done it, you will be giving the upgrading the evidence. So there is no confounders, there is no bias. Then you will be upgrading the evidence. So it depends. That's what it depends on the multiple factors, and these are the few factors the grade criteria will be analyzing to grade, to say the strength of recommendation for a particular evidence on a particular research question. Then once you have done this, you will be properly grading all these evaluations, properly analyzing it, properly reporting it, and that will be given to the panels. That will be given to the various panels in this particular team. Then they will be checking how important is your research question, how important is your evidence, how much good evidence it is. Then if they have any doubts, they'll be checking it. If nothing is there, then they will be considering that to the guidelines, and finally the guideline will be represented, the guideline will be published by saying whether that evidence can be translated into the practice, whether it can be recommended or not recommended. If it is recommending, high recommendation or strong recommendation or very strong recommendation or weak recommendation, like that. So that's how it will work. So this is the overall work of grade recommendation. So I just given you how we are going to do grade recommendation. Okay. So now once you have done this, how you are going to present it. So now you see the quality of evidence. So according to the grade I'm saying, so if we are saying that it's a high grade, it's a high according to the quality of evidence of grade recommendation, it's clearly meaning that you are very confident that the true effect lies close to that of estimate of the effect. So it's indicating that it's a highly precise, it's a highly confidence data. You can utilize that for your recommendation. So if it is a moderate, so we are moderately confident in that effect. There is a chance that this effect might be affected by the heterogeneity, or it might be affected by other confounding factors, various other factors. So we are not confident enough if you are saying that it's a moderate evidence. If it is going for a low evidence, that indicate that there is a limited value for this confidence evidence. This is limited confidence for that particular evidence. So that's how the quality of evidence will be going. If you are saying that very low, that clearly indicate that it's very weak recommendation. So that's how it will work. So according to this result, they'll be further translating into the clinical guidelines. So this is the way how you are going to present it. So there are multiple effects, like I said you, right? If it is a limitation, the study is a risk of bias. From the level 1, you will be downgrading into level 2. I given you already this presentation in the previous slide. I'm just giving you how you are going to do. If there is an inconsistency, again from the top, you will be going down. That means heterogeneity. Then indirectness. From the top, downgrading, imprecision, downgrading, publication bias, downgrading. But if there is a factor, large magnitude of effect, or it's very precise, you'll be upgrading the evidence, or you are checking the dose response gradient. If they have done that, then you will be upgrading the evidence. So that's how it will work. So these are the different factors which will influence the quality of evidence. Then how you are going to present it. So I said you that there are multiple methods to present this grade recommendation, or there are multiple methods how you present. I already shown you in the first few slides, like how they presented A, B, C, D. So if A means it's a high recommendation, it's a good recommendation. B means moderate recommendation. Low means C recommendation. D means very low recommendation. That means very weak recommendation. So that's how it will present. Either they can present as in letters, or they can present in the symbols. So if it is high means 4 plus mark will be there. If it is moderate, 3 plus mark will be there. If it is very weak, then only 1 plus mark will be there. So they can present either as a symbol or as a letter also. Even in the symbol, they can present both are upgrading, both are high quality, strength of recommendation. If it's very strong for intervention, then they will tell that both are high. That means upgrade mark will be there for both ending. Then if it is weak, then there will be a question mark. We are doubtful. Weak against an intervention. Weak against an intervention means they're opposing. We are not sure whether you can use this. It may cause some harm. If they have that kind of weak against the recommendation, then they will downgrade the evidence along with the question mark. We are not sure. But there is a strong against the intervention. You might be reading some guidelines, then you might be seeing that they will say that we are strongly against using this medicine in those particular set of population. So that means strongly against the use of intervention. In that case, both arrows will be down, going down. That means totally against. If there is a doubtful situation, we are not completely sure whether there is a good recommendation or bad recommendation. So there will be a question mark. So that's how it will work. So this is the way of presentation in the after the grade recommendation. Okay. So there is another one way of doing a grade. This is one aspect, like I said, grade recommendation. So we have another methodology also. Suppose you are taking the evidence from a meta-analysis of cohort studies. You're taking the evidence from the meta-analysis of cohort studies, then you can use this methodology. So if the evidence, if the patient, if the number of participants in that particular meta-analysis is more than 1000 and the p-value is less than 10 raised to minus 6, and the I-square heterogeneity is less than 50%, and largest component study reporting a nominal statistically significant result, and 95% prediction interval is excluding null, then no small study effect, and survive 10% of seeding effect, and there is no significant bias, then you can say that it's a class 1 evidence. Class 1 evidence means it's a convincing evidence. It's a good evidence. So that's how it will go. So suppose all these 6 to 7 criteria is not fulfilled, only 1 or 2 criteria is fulfilling. Like if it is only number of participants is more than 1000, the p-value is less than 10 raised to minus 6, and the largest steady effect is statistically significant. But it is not fulfilling about the heterogeneity, if it's not fulfilling about the ceiling effect or credibility interval, in the prediction interval, in that case, we'll say that it's highly suggestive or class 2. Suppose if it is not at all significant, the p-values itself is not significant, then you will classify into the you will classify into the lowest one, which is non-significant class of intervention. So this is the how we categorize the meta-analysis evidence of cohort studies. So there are multiple other methodologies as well. Then this is the majorly used two aspects of grading the recommendation. One is grade approach, another one is this approach. So that's how it works for the quality of evidence. Okay. So this is the basic on the levels of evidence as well as the evidence-based medicine. So in the further classes, we'll discuss more on what are the different types of filtered information and unfiltered information, then how we are going to use this particular approach. So now this is the LinkedIn profile as well as the email ID if you want to connect us back, or if you can drop down an email to fcpayofficial@gmail as well, then we can get back to you better. And before I end my presentation, I would like just to give few more information that in our under the FCPI forum, under the various forums of FCPI, we are coming up with more interactive good lectures in the future days, and in the soon day on April 26th at 7 p.m. to 8 p.m. Indian Standard Time. We have a good presentation by Dr. Abdeh Hussain Rashamwala, and he will be talking on septic shock. He'll be talking on septic shock, and this will be one of the presentation from the basic module of critical care medicine. Even critical care medicine is also launched, and they are nicely going up with their presentations. And on 26th of April, we'll have a presentation by Abdeh Hussain on septic shock. And followed by on April 27th, we'll have a talk on antimicrobial allergies as part of the infectious disease forum basic module by Dr. Nischala Reddy. She's a clinical pharmacist from Continental Hospital. And she'll be talking on antimicrobial allergies at 7:30 to 8:30 p.m. IST on April 27th. And on April 28th, we have another presentation on from the infectious disease only. That's by Aisha Sana. She's a clinical pharmacist from Aster Med City, Kochi. And she will be talking on clinically significant antimicrobial interactions on April 28th at 7 p.m. IST. So then we have so many other events are coming, because in the last week we were like, unfortunately we had to postpone few activities. We had to postpone a few presentations by Dr. Surabhi as well as Dr. Dajan Baroka, as they were not able to present at that time due to some really, like, situations where it is unavoidable. So we would like to have that presentation in the coming days, and we'll be updating on that in our social medias as well as website. So stay tuned, and we'll be like updating the information when their presentation will be happening. And thank you so much. And if you have any queries, any questions, don't forget to reach out to us. We are available on all the social medias, like we are available on the email, and this email is always open. You can shoot out any questions, and the exact expert who is expertise in that particular area will be reverting back to you with a proper answer to your query. And we are available in LinkedIn, Twitter, Instagram, YouTube, and all our Facebook. And even recently we started with the FCPA podcast as well. So that is also running so smoothly. And if you have anything, keep following us so that you will get more activity learned contents, as well as its high quality presentations as well. So thank you so much for attending this session, and thank you so much being with us. Over to you, Abdel. Thank you so much.
Thank you so much, sir. It was a wonderful presentation, and what a great way to kickstart the Research and Publication Forum. And just how important evidence-based medicine is. It's such an important tool when one has to put into a practice. I mean, when we were learning in our studies, it was such a small chapter, and now it is into our everyday practice. One has to use it. And it is not just for us, the clinical pharmacists, but it's to everyone who is attached to a patient care. whether it be a doctor, a nurse, a dietitian, or physiotherapist, each and everyone. Such an important and what a great information on how to interpret those data, how to use those evidences into the clinical practice. Thank you so much, Rashid sir. There's a couple of questions for you, Rashid sir. Like there are so many abundance of journals and articles available. So how to pick from those which evidences and which articles or journals to choose from while taking into the evidence-based medicine?
Yeah, thank you so much, Abhay, for putting that question. Because whenever we talk on research and publication, the first problem with any fresher or those who are new to the field, their major obstacle will be the same one what you are asked. So how to pick the like evidence, or even more than that, which journal is should we give more priority, or which journal we should downgrade it. So there is a way for that. Earlier days, we were always going with impact factor. So if you are going with the impact factor of the journal, stick to Thomson Reuters impact factor, because that is the only authentic impact factor in the research area. That is the only authentic impact factor which is running by Clarivate Analytics. And if you go to their website, you will be able to see what is the impact factor of each journal. So if you want to pick the evidence from a good impact factor journal, that is the way. Because whenever you see there is so much of predatory journals, there are so much of bogus journal, they will also showing some kind of impact factor in a star mark or a pop-up, something like that. Don't believe it. Don't believe it. Those impact factor is rubbish. Those impact factor is like, it won't be giving any good value. So if you are focusing on impact factor, I mean, there are multiple ways. I'll come by one. So if you're like choosing a paper or choosing a journal or choosing an article based on the impact factor, no problem. But focus on only the Thomson Reuters impact factor. Go to the Clarivate Analytics, you will be getting the proper impact factor, and they will be updating, I think, each every 6 months, or they'll be updating every 1 year. I'm not sure about that, but go with the Clarivate Analytics impact factor that we other way we call it as this Thomson Reuters impact factor. So that is the one way of choosing the best journals or best article. The other way is that you see the indexing of that journal, which databases those journals are indexed. So if your academic, there are multiple ways with each academy or each university or each institution will have different set of guidelines to choose the evidence. Suppose if I talk some Indian academic institutes, we say that you go with the Scopus. But if you're going with the Scopus, again in the Scopus, there are 4 category of the journals. So there is a top category, which we call it as quarter one. Quarter one means it is above 75% of the total journals in that area. Suppose your journal is on the top 10 of 100. So that means that it is on the top 10. That means it is above the 90%, right? So that's how it will work. So they will rank your journal to the total number of journals in that particular area. Suppose your journal is in the critical care area. So they will see that journal is on the which position among the all the journals in that particular area. So accordingly, they will be categorizing the journals into 4 categories. So the one is top one, that is Q1 journals. We say Q1 means they ranked between on the top 25. Top 25 in between the 75 to 100 percentage. That's how you have to. Vice versa, you have to think. On the top 10 means or top Q1 means it will be on the top level, top 25 percentage. That means 75 percentage to 100 percentage. Then it will go to Q2. Q2 means 50 percentage to 75 percentage. Q3 means 25 percentage to 50 percentage. Q4 means less than 25 percentage. So if you are picking an evidence from the top 25 percentage, that will have more value than the evidence which you choose from a Q2, from the quarter two. So that is another way to see. So there is something other thing is called as JCR, Journal Citation Report. So they will check how many citations that particular journal is getting, how many citations that particular article is getting. So if the JCR report is well and good, that will also count as a good quality evidence. And other way, you see whether that is indexed in a reputed good database like PubMed. If the journal is already available in the PubMed, if that article is already available in the PubMed, then there is a catalog in the PubMed. If you see the PubMed, there will be a top 2 column. One column is a small, another one is a big column. So if you just click that drop box in the top column, there will be journal catalog. And if you put the name of that journal, and that journal is still indexing with the Medline or PubMed, that is also one way of seeing whether the journal is having a good credibility. So there are multiple other ways also, but in our way, this will be the best few methods which you can see that whether it is having a good, and there are some other things like ACCP and all. They have a good journal. So you see the organization which runs by, which journal is running by, which I'm not telling only one organization. So like that, there are multiple organizations. So you might be knowing which is the good organization running in your particular area. And if they have a good journal, which is producing good article also, there is nothing wrong in taking that article. So in this question, the thing is like it depends on your area, depends on your perception, or depends on you how you want to categorize your article. There are multiple ways, like I said. So if you ask me as a researcher, I'll be always looking to the risk of bias in that particular article. I'll be looking to the methodological quality of the article, because I'm not focusing on the decision making. I am focusing on how that particular research is done. I'm looking to the methodological quality of the article. So it depends on your perception, depends on how you want to grade your article. So otherwise, these are the multiple ways to see which journal is good enough, which journal is, or which article is good enough, which article is not good enough. So there are multiple ways, but these are the few tips for that.
Rightly said, sir. I think so it is one of the major questions when one intern or any new student who comes up while practicing. And I would also like to ask, like when the data is very less or there's a conflicting data in the evidence that is there. So how would or what caution one should take while assessing that evidence and also implementing that evidence into practice?
Yes, that's also a good point up there. So, but you need to see the background of that particular research. Suppose you see a area. Suppose you take an area like respiratory diseases, or you take something called as COPD. But you know that how much usually in an year or 2 year, how much cases will happen, right? So if I work in ARDS, I know that in my hospital there will be a minimum of 200 to approximately 250 cases in a year, right? So I know that this much cases will happen in a year, and I am producing a paper with 20 patients, 25 patients. Will that make any sense? No. So the number of patients in each article will be depends on the research area. So suppose there is an area like your Guillain-Barré syndrome, GBS. It's very rare to get one patient like that, and article is reporting hardly 50 cases in a year or 2 year. They are reporting 50 cases, but that 50 cases is good enough for us to decide what treatment should be given, what is to be done, or something called it as poison cases. 50 to 100 patient would be good enough to decide whether it can be included. But still you need to check the effect measure, odds ratio, hazard ratio, and other effect measure along with the significance, p-value and all. But there is something called it as statistical significance and clinical significance. We may have good talks in the future, maybe under research and publication forum on that. But you just remember these words. Not always statistical p-value will matter. You need to have the interpretation ability according to your clinical significance also. So we will be more discussing on what is the difference between a statistical significance and clinical significance in the future classes. But all these factors will come into the picture when you talk about the sample size, even power of the study, the alpha error of the study, beta error of the study, or how which sample size methodology you have adopted to see the participant sample size in the study, or whether you met the number of participants size you required, because you are saying that you need minimum of these many participants and the research is not fulfilling that criteria, then it will be difficult. So these all will come into the matter when I see how many participant minimum we require to conduct a research. So there are multiple other things also will come into the picture. Maybe we will discuss all those aspects in the future classes of our research and publication forum.
Yes, sir. Definitely the upcoming modules will answer those questions, hopefully, for the candidates. And just one last question, or it's not a question, but what will advice or any roadmap that you would suggest for a learning student or a new practitioner who wants to, grow on their knowledge on evidence-based medicine and clinical practice.
Yeah, perfect. So the thing is like when you, as I mentioned in the first thing, uh, you want to expose, you want to get into the evidence base. Obviously, your clinical practice is the most important. See, you as a critical care clinical pharmacist, you are focusing on something like infectious disease. It may not match when you are trying to understand the literature in infectious disease. I had a situation where when I was reading in the first few days of my kind of research, I was keep on reading the articles which is there in the pharmacogenomics, which is there in the genetics section. I keep on reading, but I don't understand anything from that. Then what evidence I will make out of it? There is no point in that. So as I mentioned, the first thing is that your research area or your practice area make the most important stand there. So in that particular area, there will be multiple things to see. So you see the critical care medicine. In critical care medicine, what aspect you are for focusing? Even I say that even antimicrobial stewardship is too vast. Everyone cannot focus only on all antimicrobial stewardship. It's not possible. So they have to focus on particular disease condition, or they have to focus on a particular antimicrobial agent. So it depends like that. So when you see what is the goal in the sense, first goal is that you need to decide what area you are working and what kind of evidences you get. See, the major obstacle for me as a critical care researcher or critical care pharmacist, you can't have much RCTs with a good sample size. Why? Because the ethical committee will not allow you to conduct an RCT or to start a new intervention very easily, right? So conducting an RCT until it is a mild or moderate disease, they will allow you to conduct in a critical care setting. But if it is a death condition or it's a like a kind of very critical disease, will they allow to easily start an RCT there? It's not possible at all. So that is where you need to decide what is your area. Then you will be thinking of what are the more research is available in that area. Then you start learning. When you suppose your area you are getting more RCTs, then you start learning how to grade the RCTs. What is more in depth I should learn about RCTs? What is the more things I should learn about RCTs? So that would be a good way for a practitioner or for a person who are involved in practice also, and he need to learn about evidence-based medicine also. Otherwise, a full-time researcher can focus every study design, not a problem. He can focus on every other aspects of research also, no problem. But as a practitioner, he want to put some side time only for this aspect, then this would be a better way to achieve it.
Rightly put, sir. Thank you so much. And it was a wonderful session on evidence-based medicine. I thank you everyone who has joined today and looking forward to everyone participating in further modules to learn more and more about clinical pharmacy and clinical pharmacy practice. Thank you once again. Thank you, Rashid.
Thank you, Abder, for moderating the session, and thank you everyone for joining.